Hello, my name is Jacqueline Bitsavich, and I'm continuing my video presentation. This week I will be talking about the pharmacology of a cerebrovascular accident. My objectives for the learner: they will be able to understand and explain the common classification of medications to treat a cerebrovascular accident or CVA, describe the pharmacology of 3 different medications in relation to the pathophysiology of an ischemic CVA, discuss the nursing implications for adverse drug events specific to identified drugs, and investigate new developments in potential treatments for an ischemic CVA. Cerebrovascular accident, or a CVA, there are mainly 2 types or causes of a CVA, ischemic or hemorrhagic. Both are an interruption of the blood flow to the part of the brain that results in tissue hypoperfusion, tissue hypoxia, and brain cell death. 87% are ischemic CVAs, is an occlusion or a blockage in the vessel in the brain. 10% are hemorrhagic CVAs, which is caused by bleeding in the brain from hypertension, over treatment of anticoagulants, or a weakened area in the vessel wall. And there's a third type of stroke, which is 3% caused as cryptogenic strokes of unknown cause. Ischemic CVA occur when there is an occlusion or blockage in the vessel in the brain caused by a thrombotic or embolic. A thrombotic stroke typically happens when an occlusion occurs from a thrombus inside an artery in the brain that forms. An embolic stroke typically occurs when a piece of a thrombus breaks off or breaks loose and is carried in the circulation and accumulates to block the cerebral vessel, causing an ischemic stroke. A hemorrhagic stroke is bleeding that develops within the brain. It could be intercerebral, interventricular, or subarachnoid hemorrhage. There is a sudden development of symptoms that causes the stroke. The symptoms are dependent upon the area of the brain that is affected. The most common symptoms of a stroke are a sudden period of confusion, loss of alertness or change in level of consciousness, sudden trouble speaking or understanding, weakness in the facial muscles, sudden trouble seeing in one or both eyes, sudden weakness, paralysis, or partial trouble or complete loss of voluntary movement or sensation, numbness and tingling using an arm or leg or both, or a sudden severe headache. Any of these findings can be the beginning symptoms of a CVA, which each symptom is contingent upon the region within the brain being affected. The symptoms occur due to a sudden death of brain cells due to the lack of oxygen when the blood flow in the brain is impaired by the blockage. A CVA or stroke is a medical emergency and immediately action needs to be placed. With the effects of immediate attention and appropriate medication, there can be complete reversal, partial improvement, or the patient is left with these devastating results. A brief explanation of the pathophysiology of an ischemic CVA or stroke process initiates by the sudden interruption of cerebral blood flow, thrombus formation in the vessels, platelet aggregation process caused by the exposed subendothelium. The platelet releases adenosine diphosphate, or ADP, that causes platelet aggregation and consolidation of platelet accumulation. Thromboxane A2 is released, contributing to platelet aggregation and vasoconstriction that can accelerate the onset of symptoms. The damage to the vessel activates the coagulation cascade of cellular consequences and our complex and dynamic response of excitotoxicity, mitochondrial dysfunction, and oxidative stressors that can lead to thrombin production, causing cell necrosis. Thrombin converts into fibrinogen to fibrin, which can lead to clot formation as fibrin molecules, platelets, and blood cell aggregate. Improved regulation and a well-developed understanding of how the excitatory-inhibitory balance is disrupted after having a stroke is critical to designing therapeutic approaches in stroke recovery. Cellular insults incurred following a stroke, neural circuits are also disrupted due to the shifts in the excitatory-inhibitory balance in the neural networks. Each component of the pathophysiology response following a stroke on both the cellular and the circuit level represents an opportunity for limiting initial injury and hastening recovery. The diversity of having a stroke and patient-specific characteristics such as collaterals and vascular composition can play a significant part in the rehabilitation. This is also critical for the ultimate success of recovery. Researchers gain the insight and the ability to manipulate multiple recovery pathways or effective neuroprotective therapies will emerge. The pathology of the disease process can be affected by having the appropriate medication that can cause delay of process of the stroke, improve the effects of a stroke or CVA, or completely reverse or cure the possible effects or devastating effects of a stroke. The pathophysiology of a hemorrhagic stroke process initiates by bleeding within the brain tissue and surrounding space, resulting in compression, causing edema. The bleeding can stop or continue to enlarge. Arterial hypertension causes hyaline degeneration and fibrinogen necrosis in the weakened arteries that supplement the brain that can cause vessel walls to weaken and be the cause of the bleeding, a ruptured aneurysm, or an arterial venous malformation. A hemorrhagic stroke can be, as already mentioned, intracerebral, interventricular, or subarachnoid hemorrhage. Common classification of medications to treat an ischemic CVA. One major assessment patients can be affected by is knowing the type of stroke the patient is having. It could be either ischemic or hemorrhagic, as already explained. To identify this, a stat non-contrast CAT scan needs to be completed and immediately read by a neurologist or a neurointensivist to appropriately begin proper treatment for the patient. Usually and typically, blood work is also drawn, and the coagulation panel studies can be important to assess if there is potential cause for the stroke from medication like Coumadin or warfarin or any other anticoagulants due to elevated or prolonged clotting time. Alteplase or tissue plasminogen activate TPA, antiplatelet medications, anticoagulants, antihypertensives, and stat medication. An explanation of the pathology of an ischemic stroke and what effects of medication on the body. A CVA is caused by platelet aggregation. TPA and aspirin at the cellular level breaks up the thrombotic or embolic clot. The platelets release adenosine diphosphate or ADP that causes platelet aggregation and consolidation of the platelet accumulation. Thromboxane A2 is released, contributing to the platelet aggregation and vasoconstriction that can accelerate the onset of symptoms, which TPA and aspirin inhibit this thrombotic and embolic formation, which makes alteplase, TPA, and aspirin effective. Anticoagulant medications thin the blood, reducing the clotting cascade and preventing clot formation of the blood in the vessels. Antihypertension medication produces significant decrease in the systemic vascular resistance. A type of medication, acardipine, inhibits the influx of calcium ions into the cardiac and smooth muscles, which act specifically on the vascular muscles. It causes a decrease in the cardiac output, in return causes a vasodilatory effect, which its primary effect is in reduction in the blood pressure. Statin medications are a class of drugs often prescribed by physicians to help lower cholesterol levels in the blood, preventing cholesterol accumulation. By lowering the levels of cholesterol, they help prevent heart attacks and strokes. This makes this medication effective. Studies show that in certain people, statins reduce the risk of heart attack and stroke, even death from heart disease, by about 25 to 35%. Primarily, my focus will be on the pharmacology of 3 different medications in relation to the pathophysiology of an ischemic stroke, which is alteplase, tissue plasminogen activate, TPA, which is a protein thrombolytic fibrinolytic enzyme therapy, aspirin, which is an antiplatelet, and acardipine, which is an antihypertensive. I will explain each medication in detail. First-line ischemic stroke medication is alteplase and TPA. Thrombolytic fibrinolytic enzymatic therapy is the only medical treatment option for an acute ischemic stroke. Certain criteria needs to be met for the fibrinolytic therapy of alteplase. Early reperfusion therapy with fibrinolytics or thrombolytics in ischemic CVA patients is the appropriate care for improving neurological outcomes. Alteplase or TPA is the only medication approved by the Food and Drug Administration labeling for treatment of acute ischemic strokes. Thrombolysis medication agent was developed in 1996, and there has been no further new medication approved by the FDA for ischemic strokes. Alteplase provides the greatest benefit in the treatment of acute ischemic strokes when it is given within 3 to 4 hours of initial onset of symptoms. Having a multidisciplinary approach ensuring proper triage with identification of patients who could benefit from Alteplase. After a patient has had an ischemic stroke, if they do not meet the criteria to be able to receive Alteplase or TPA, then the patient can receive an aspirin, which is an antiplatelet medication. If a patient has received Alteplase or TPA, aspirin or any other antiplatelet medication is contraindicated immediately, but the patient should be placed on aspirin or the antiplatelet medication within 24 to 48 hours after receiving Alteplase or TPA. And then they will continue the medication daily thereafter. Antihypertension medication is started if the patient's blood pressure is elevated, maintaining the blood pressure parameter that the physician has ordered and wants the patient's blood pressure to be monitored at. Hypertension is one of the major risk factors for having a CVA or a stroke. Blood pressure control is an important secondary prevention. Maintaining blood pressure parameters according to the physician's ordered parameters for a patient in the intensive care unit commonly ordered is intravenous nicardipine, which is a continuous infusion, or PRN IV dose of labetalol for blood pressure control. Then the patient, after post-CVA, is transitioned to oral hypertensives. There is specific inclusion and exclusion criteria that has to be met prior to being able to receive Alteplase. Just to mention a few are the negative CAT scan showing that there is no hemorrhage or bleed on the CAT scan, no recent surgeries, or no active known bleeding. Maintaining blood pressure parameters, systolic blood pressure less than 180, diastolic blood pressure less than 110 millimeters of mercury, and maintaining, even with the infusion of the medication, blood pressure less than 180 over 105 millimeters of mercury. Antihypertensive medications can be administered to maintain these parameters. Maintaining blood pressure parameters is closely monitored in the intensive care unit, making sure that the patient's pressure doesn't rise so that they don't develop any bleeding. The pharmacology of Alteplase or TPA. Classification of medication. Pharmacological classification is an enzyme. Therapeutic classification is a protein, thrombolytic, fibrinolytic enzyme therapy. The mechanism of action in the body. Alteplase is an enzyme and a systemic thrombolytic that helps break down or dissolve clots. A baseline set of labs should be drawn, but effects on the lab results post-infusion has not been reported of any changes. Administration of Alteplase is intravenous. Maximum dose weight based is 90 milligrams. Administering 10% of the dose IV bolus over the first minute, and then the remaining 90% over the next hour, following with the saline infusion flush to ensure that the patient receives the full dose. Metabolism occurs primarily hepatically, rapidly clears from the plasma by the liver. 80% of the dose is cleared within the first 10 minutes after infusion is completed. Excretion is more than 85% is excreted in the urine and 5% in the feces. The plasma half-life is less than 10 minutes. Onset is immediate and peak is within 45 minutes, and duration of the medication in the system lasts up to 4 hours. Pathophysiology of the medication for ischemic strokes. Thrombolytic fibrinolytic action of Alteplase is the serine endopeptidase synthesis of endothelial cells. The major physiological activator of plasminogen is when bound with fibrin clots to catalyze the conversion of tissue plasminogen to plasmin by hydrolysis of specific arginine-valin bond. The fibrin specifically produces local fibrolysis in the area of recent clot formation. With limited systemic proteolysis, in patients that are having a severe stroke or a myocardial infarction, this allows reperfusion of the ischemic brain flow or the cardiac muscle area which the blockage occurs within the brain of the heart. Age factors. There are age limitations for patients over the age of 18. Safety and efficacy of use in children has not been established. Carefully assessing patients that are older than 75 years or older, because elderly patients have an increased risk for adverse cardiovascular effects. It's up to the discretion of the physician, talking with the patient, weighing out the pros and the risks and benefits for the overall recovery of the patient or the best optimal outcomes. Dosage adjustments are a maximum weight base of 90 milligrams. The efficacy of the medication is to return to baseline. Initial stroke symptoms resolve or improve. Important assessments are improvement from baseline, neurological assessment, obtain baseline labs, a complete blood count including hemoglobin hematocrit, platelet count, prothrombin time, INR, activated partial thromboplastin time, assessing coagulant panels, renal function panel, assessing BUN and creatinine, glucose levels, and also having an estimated glomerular filtration rate, assessing kidney function. Side effects and major adverse effects of the medication contraindicated for patients that have received alteplase or TPA or have had hemorrhagic conversion from receiving the medication or induced active bleeding. Adverse effects or reactions can include central nervous system, cerebral hemorrhage, cerebral edema, or worsening CVA. Respiratory complications can be pulmonary edema or laryngeal edema. Cardiovascular effects can be hypotension, arrhythmias, edema, bradycardia, recurrent ischemia, pericardial effusions, pericarditis, arrhythmias, cardiogenic shock, heart failure, cardiac arrest, cardiac tamponade, myocardial rupture, embolization, or venous thrombosis. Gastrointestinal effects can be nausea and vomiting or GI bleeding. Hematological effects can be severe or spontaneous bleeding in the cerebral peritoneal areas and bone marrow depression. GU can have effects of urinary tract bleeding. Integumentary is bruising or flushing of the skin and musculoskeletal pains. Other effects of the medication can be bleeding at the puncture sites, fever, rash, phlebitis, sepsis, hypersensitivity to the substance, or anaphylaxis. Important patient teaching includes teaching the patient signs and symptoms of internal bleeding or hemorrhage. There is limited time of administration, can only be within 3 to 4.5 hours of onset of stroke symptoms. After the administration of alteplase or TPA, close intensive care monitoring will occur for within the first 24 to 48 hours following, and also follow up CAT scan imaging within 24 hours to make sure that there's no hemorrhagic conversion. Pharmacology of aspirin. Aspirin classification of medication. Pharmacological classification is salicylate. Therapeutic classification is non-narcotic analgesic, antipyretic, anti-inflammatory, and antiplatelet effects. Mechanisms of action in the body. Aspirin analgesic action produces central action of analgesia by an ill-defined effect on the hypothalamus, and peripheral action by blocking pain impulses, which involve blocking prostaglandin synthesis via inhibition of the siloxane oxygenase enzyme. Antipyretic actions relieves fever by acting on the hypothalamic heat regulatory center to produce peripheral vasodilation. This increases the peripheral blood flow and supply and promotes diaphoresis, which in return leads to loss of heat and to cooling by evaporation. Anti-inflammatory action, exact mechanism is unknown, but is believed to inhibit prostaglandin synthesis and inhibit the synthesis or action of other mediators of inflammation. Absorption is rapid and complete by the gastrointestinal tract. Distribution is widely into the body systems, tissues, and fluids. Protein binding to albumin and concentration dependent on the range from 75 to 80% and decrease as serum levels increase. Severe toxic effects may occur at serum levels greater than 400 milliequivalents per milliliter. Metabolism is hydrolyzed partially in the gastrointestinal tract to salicylic acid, and almost complete metabolism in the liver. Excretion is in the urine as salicylate and its metabolites, and elimination half-life ranges from 15 to 20 minutes. The pathophysiology of the medication for ischemic strokes: aspirin's antiplatelet and anticoagulant action could be either at low doses, 81 milligrams of aspirin, or higher doses at 325 milligrams. Aspirin impedes the clotting by blocking prostaglandin synthesis actions, which improves formation of the platelet aggregating substance thromboxane A2. This interference with the platelet activity is irreversible and can prolong bleeding time. At higher doses, aspirin interferes with the prostacyclin production, a potent vasoconstrictor and inhibitor of platelet aggregation, possibly negating its anti-clotting properties. Age factors associated with aspirin, even children's aspirin, should never be given to children or teenagers with flu-like symptoms or chickenpox. Aspirin can cause Reye's syndrome, a life-threatening condition that affects the nervous system and the liver. As many as 30% of children and teenagers who develop Reye's syndrome will die. Those who survive will have permanent brain damage. Dosage adjustments for aspirin: do not take more than the recommended daily dosage. Do not use more than 5 times per day or longer than 5 days. Geriatric contraindication: patients older than 60 years age or older may be more susceptible to toxic effects of aspirin. Used cautiously. Effects of aspirin on the renal prostaglandins may cause fluid retention, and no one should take aspirin more than 10 days in a row unless told by or directed by a physician. Anyone with a fever should not take aspirin more than 3 days without a physician's consent. Efficacy of the medication is analgesic action, reduction in pain, anti-inflammatory action, reduction with inflammation, antipyretic effects, reduction in fever, antiplatelet or anticoagulant action, impedes the clotting properties. Taking aspirin may cause effects on lab results, primarily increasing serum BUN and creatinine levels, which can cause renal insufficiency, may increase liver function test values that can cause liver dysfunction or hepatitis, may decrease white blood cell count and platelet count, so commonly assessing prothrombin time, INR, activated partial thromboblastin time, or APTT, assessing coagulant panels due to the antiplatelet and anticoagulant effects. Side effects and major adverse effects of the medication aspirin: contraindicated in patients with hypersensitivity to aspirin drug and those with bleeding disorders such as hemophilia, the G6PD deficiency or von Wildenberg disease, also contraindicated in patients with non-steroidal anti-inflammatory induced sensitivity reactions and in children. Use caution in patients with GI lesions, impaired renal function, hypoprothrombonemia, vitamin K deficiency, thrombotic thrombocytopenia purpura, or hepatic impairment. Ear, eyes, nose, and throat can cause ringing in the ears or hearing loss. Gastrointestinal effects can be nausea, vomiting, assessing for GI distress, occult bleeding, dyspepsia. GI bleeding, gastrourinary, can assess for any hematuria or acute renal insufficiency. Hematological effects would be leukopenia, thrombocytopenia, prolonged bleeding time, blood coagulation defects, vitamin K deficiency caused by dehydration, concurrent anticoagulant use. Hepatic effects can be liver dysfunction and hepatitis. Integumentary can cause rash, bruising, urticaria. Other hypersensitivity reactions such as anaphylaxis, mainly common associated with asthma, angioedema, hypersensitivity to salicylates or other non-steroidal anti-inflammatories, or tazine. Important patient teaching: following the physician's recommendation should not be started 24 to 48 hours after having an acute ischemic stroke. Benefits are to reduce the risks of death and recurrent stroke. Patients should keep aspirin out of the reach of children's reach. Encouraged to use child-resistant closures on their lids because aspirin is the leading cause of childhood poisonings. Avoid taking aspirin during pregnancy, especially in the 3rd trimester, or breastfeeding, because aspirin has been found in breast milk. Advise patients receiving high doses of long-term aspirin therapy to watch for increased bleeding possibilities, such as petechiae or red dots on the skin, bleeding gums, and signs of gastrointestinal bleeding. Instruct patients to avoid use of aspirin if allergic or tartrettian dye, and tell patients to take aspirin with food or after meals to avoid GI upset. The last and final pharmacology of nicardipine medication is classified as a dihydropyridines. Pharmacological classification is a calcium channel blocker, and therapeutic classification is an anti-anginal and antihypertensive. The mechanism of action of nicardipine is an antihypertensive. Hemodynamically, nicardipine intravenously produces significant decrease in the systemic vascular resistance. An increase in the heart rate is normal response to vasodilatation and decrease in the blood pressure. In some patients, these increases in heart rate can be pronounced. Coronary dilatation induced by nicardipine intravenously improves perfusion and aerobic metabolism in the area of chronic ischemia, resulting in reduction of lactate production and augmented oxygen consumption. More than 90% of the medication is bound to the plasma protein during distribution. A substantial first pass effect metabolism reduces absolute bioavailability to about 35%. The drug is extensively metabolized in the liver. Excretion and elimination of the medication half-life of the drug is about 8.5 hours after steady state levels are reached. The pathophysiology of the medication for ischemic CVAs, nicardipine is a calcium channel blocker, shown to inhibit the intracellular migration of calcium ions, which in return slows the movement of calcium into the cells of the heart and the blood vessels. This, in return, relaxes blood vessels, increases the supply of oxygen-rich blood to the heart, and reduces the heart's workload. Nicardipine inhibits the influx of calcium ions into the cardiac and smooth muscles, which acts specifically on the vascular muscles. It can cause a smaller decrease in the cardiac output than other calcium channel blockers because of its vasodilatory effects, which its primary effect is reduction in the blood pressure. Age-related effects not recommended in the pediatric population and not recommended in children younger than the age of 18. In patients that are older than 75 years or older, use cautiously because elderly have an increased risk of adverse cardiovascular effects, reflex tachycardia, and hypotension. It is up to the discretion of the physician to order this medication for the patient. Low initial doses in the elderly, reflecting the greater frequency of decreased hepatic and renal and cardiac functions, which makes this other drug medication a better drug therapy. Efficacy of the medication is reduction in hypertension. No specific clinical effects were reported on lab results or lab tests. Side effects and major adverse effects of the medication contraindicated in patients for hypersensitivity to other calcium channel blockers or nicardipine drugs, and those with advanced aortic stenosis. Used cautiously in patients with impaired renal or hepatic function, cardiac conduction disturbances, hypotension, or cardiac failure. Adverse reactions in the central nervous system are related effects are dizziness, lightheadedness, headache, paresthesia. Cardiovascular effects can be peripheral edema, palpitations, angina, reflex tachycardia, and flushing. Gastrointestinal effects can be nausea, abdominal discomfort, dry mouth. Integumentary effects can be a rash. Important patient teaching is to tell and instruct the patient to take the medication, the oral form of the drug exactly as prescribed. And advise patients to report any chest pain immediately, along with any complaints of hypotension, lightheadedness, dizziness, sudden headache. Some patients may experience increased frequency, severity, or duration of chest pain at the beginning of the therapy or during dosage adjustments. Interactions of drug-to-drug medication with nicardipine and medications such as Tagamet increase the nicardipine levels. Monitor patients for increased effects. Cyclosporin effect increase increase the cyclosporin levels, assess especially in transplant patients and anti-rejection medications, monitor patients very closely. Fentanyl anesthesia causes severe hypotension in conjunction with nicardipine, monitoring blood pressures frequently. Other drug and food alterations are grapefruit juice increases the bioavailability of the medication. Advise patients to avoid taking this drug with grapefruit juice. High fat meals decreases the bioavailability of nicardipine by 20 to 30%. So, and tell patients to take the drug between meals if possible. Nursing implications for adverse drug effects to the specific drugs alteplase, TPA, aspirin, and nicardipine. Alteplase and TPN nursing implications are carefully and closely monitoring patients post-infusion, assessing for internal bleeding or hemorrhage, or reactions associated to adverse drug effects. Administration is intravenous within 3 to 4.5 hours of onset of stroke symptoms. A pharmacist prepares the individual weight-dosed medication. A dosage adjustment limitation is limited dosage weight based of 90 milligrams. So if a patient is greater than 100 kilograms, you would still give 90 milligrams, but then it is weight-based appropriate if less than that dosage. Metabolism primarily occurs in the liver, rapidly clearing the plasma by liver. Excreted is more than 85% in the urine and 5% in the feces. The medication peaks within less than 10 minutes of onset, and the peak is within 45 minutes, and the medication duration is 4 hours. Post-infusion therapy, avoid intramuscular injections, venipunctures, or arterial punctures. If necessary to do a puncture, apply pressure to the site for about 30 minutes or until the bleeding has stopped, and frequently assessing the dressings. Sometimes applying ice packs can also prevent further bleeding. Contraindications in patients with history or evidence of intracranial hemorrhage, suspected subarachnoid hemorrhage, seizures at onset of a stroke or CVA, or recurrent or recent CVAs within the last 2 months. Contraindications in any active internal bleeding, arterial venous malformation, aneurysms, or severe uncontrolled hypertension, having uncontrolled pressures greater than 185 millimeters of mercury systolic or greater than 110 millimeters of mercury diastolic blood pressures. Contraindication with patients of pregnancy, patients within the first 10 days postpartum, or patients that have had recent surgery, or GI or GU bleeding, or hepatic dysfunction. Use cautiously in patients receiving anticoagulants and patients aged greater than 75 or 80 years old. Aspirin nursing implications aspirin can interfere with urinary glucose analysis testing. Serum uric acid levels may be falsely increased. Salicylates must be used cautiously in patients with a history of GI distress, especially peptic ulcer disease, increasing the risk of GI bleed or decreased renal function, assessing patients for adverse effects. Aspirin tablets can be chewed, broken, or crumbled and administered in food or fluids to aid in swallowing. Uncoated plain aspirin tablets allowed to remain in contact with the mucous membranes of the mouth or the esophagus can cause mucal erosions or mouth ulcerations. Patients should take at least 8 ounces or 240 milliliters of water or milk with salicylates to ensure passage into the stomach. Advise patients to sit up for about 15 to 30 minutes after taking salicylates to prevent lodging of salicylates in the esophagus. Enterocotic products are absorbed slowly and aren't suitable for acute therapy. Monitoring of vital signs frequently, especially temperature, should be assessed on patients. Salicylates may mask other signs and symptoms of acute infection, such as fever, malaise, and erythema. Careful evaluation of patients are at risk for infections, especially diabetic patients. Monitor complete blood counts, monitoring platelet counts, your ProTime, INR, BUN, creatinine serum, creatinine, and liver function studies periodically during salicylate therapy to detect any abnormalities. Assess the patient for any signs and symptoms of hemorrhage, as coffee ground vomitus or black tarry stools. Stop aspirin therapy 1 week prior to elective surgeries, if possible. Adults should not use the drug or self-medicate for longer than 10 days. Moisture may affect aspirin and lose its potency. Store in a cool, dry place. Aspirin may be used for prevention of complications in pregnancy, including preeclampsia, pregnancy loss with complications of antiphospholipid syndrome, or recurrent pregnancy loss. Just follow the recommendations of a physician. Avoid aspirin with breastfeeding patients because salicylates appears in breast milk, so avoid during breastfeeding. Nicardipine. Nursing implications when caring for a patient that is receiving nicardipine are closely assessing for adverse drug effects and watch for patients that can develop hypotension, bradycardia, drowsiness, confusion, and slurred speech. Treatment is notifying the physician, stopping the infusion, and provide supportive measurements as needed per the physician, which can include starting vasopressors. Calcium gluconate given IV may be useful to counteract the effects of nicardipine. Special considerations are to allow at least 3 days between oral dosage changes to ensure steady state of plasma levels. When treating hypertension, assess and monitor and measure blood pressure frequently to assess the medication's effectiveness. When using IV route, change the IV sites every 12 hours to minimize vein irritation, and administering primarily through a central line is the best route. Also, again, patients that are breastfeeding or post-pregnant patients, breastfeeding is not recommended. Substantial levels of nicardipine have been found in breast milk. Age-related issues and the Bears criteria. According to the Bears criteria, this guide indicates that there are some medications that should be avoided in the elderly altogether, and some that should be avoided in the presence of certain medical conditions. Some medications are appropriate to use, but with caution in the elderly. It is ultimately up to the patient and the physician to address the risks and benefits of taking a medication. This list and recommendations are a developmental tool to assist healthcare providers in improving medication safety in the elderly. Implications associated with these medications and adverse drug events. Changes brought about by aging make elders more vulnerable to the harmful effects of some medications. In older adults, physiological changes occur, such as the reduced liver size and liver blood flow, with a resulting reduction in liver metabolism, and reduced kidney size and blood flow results in reduction of renal clearance. There are multiple risk factors that elderly patients are associated with having adverse drug reactions. Some are multiple comorbidities or disabilities that require polypharmacy regimes. Elderly patients can have several factors related to altering drug distribution, drug metabolism, and drug effects that can change a drug's pharmacokinetics and pharmacodynamics. The elderly population can also have cognitive problems that can contribute to adverse drug reactions that can lead to adherence. When a patient has to take multiple drugs, they can get confused and also increase the risks of error leading to adverse drug reactions. Reviewing a patient's medication record should be checked frequently to evaluate any unnecessary drug therapy. If a patient should not be taking this medication due to being over a certain age, or patients can take duplicate medications or therapies to avoid adverse drug reactions. The incidence of drug-related adverse events can be reduced by carefully selecting drug agents and appropriate dosage regimes. Elderly patients have age-related changes with their renal, hepatic, and cardiac functions, in which can potentially harm the elderly patient from taking medications. Impaired or failure of the kidneys, liver, and heart can affect drug absorption, distribution, bioavailability, and metabolism, and drug clearances. Alteplase is not listed on the Bears criteria, but other thrombolytic medications are, and the rationale is to use with caution in adults that are 75 years or older, or patients with creatinine clearance less than 30 milliliters per minute. Adverse drug effects are increased risk of bleeding compared to other thrombolytic medications, and reported rates with other specific targeted oral anticoagulants in patients that are older than 75 to 80 years old. Lack of evidence of efficacy and safety in the elderly population. Individual patients' considerations include in this thought process have to be the life expectancy, level of function, and important factors to consider when determining whether alteplase or TPA should provide clinical overall meaningful benefit to the patient. Aspirin, level of harm and adverse effects. Avoid chronic use unless other alternatives are not effective, and patients can take gastropreventative agents such as a proton pump inhibitors. Adverse drug effects on patients is increased risk of gastrointestinal bleeding or peptic ulcer disease in high-risk groups, including patients that are 75 years or older, or taking oral or parenteral corticosteroids, anticoagulants, or antiplatelet agents. Advise taking a proton pump inhibitor. Upper gastrointestinal ulcers, gross bleeding, or perforation caused by nonsteroidal anti-inflammatories occur in about 1% of patients treated for 3 to 6 months. Aspirin should be used with caution in patients greater than 80 years or older. Lack of evidence or benefit versus the risks in patients 80 years or older. Document level of harm based on the Bears criteria. The quality of evidence was low to moderate, and strength of recommendations was strong. Nicardipine is an antihypertensive calcium channel blocker, was not listed on the Bears criteria, but other vasodilator medication was listed and advised to use in caution with elderly patients. Other antihypertensions were listed. Adverse drug effects are to avoid in elderly patients due to the high risk of syncope or exacerbated episodes of syncope by potential causes of orthostatic hypotension, bradycardia, and suggested better agents are available. Document level of harm based on the Bears criteria. The quality of evidence was moderate and strong recommendations was weak. New development and potential treatments for ischemic strokes. Alteplase and TPA is the only FDA-approved medication treatment for ischemic strokes. There is no new approved thrombolysis or fibrolytic medication since 1996, when alteplase and TPA was developed and approved. There has been no further developments, according to the Food and Drug Administration, to effectively treat ischemic stroke. Telehealth or telemedicine is a type of virtual care access for patients for potential stroke symptoms. In other hospitals that are primary stroke centers, prior to transferring a patient that is having a stroke to a comprehensive stroke center to get the cutting-edge service that a stroke patient may need. Patients increasingly want to seek healthcare by video or email as a form of healthcare delivery. Virtual care is an advanced way to deliver healthcare to patients by utilizing technology in order to provide comprehensive healthcare to a remote location to a patient anywhere. Virtual care has had potential merit to opening the doors to many opportunities in healthcare by broadening assessments, education, diagnosis, basic treatment, management, monitoring capabilities, and provider-to-provider interactions. Virtual care can promote an increase in patient satisfaction and immediate engagement with physicians and other healthcare providers. The physicians are notified of potential stroke patients. The emergency medical services identify the nearest emergency department of any incoming stroke patients or patients with potential stroke symptoms. Virtual care of strokes can be incorporated here by assessing the patient before the patient even reaches the hospital. There are mobile stroke units, ambulances, that contain a CAT scanner and the appropriate medication, which is alteplase or TPA. Utilizing advanced forms of stroke assessment can enhance care for such a time-constrained diagnosis. This immediate triage method promotes early diagnostic testing and initiates emergency medicine physicians and the neurologists to promptly evaluate patients, and treatment can begin before the patient even hits the emergency room doors. Another new development of treatments and potential treatments of ischemic stroke is endovascular therapy or thrombectomy in intervention and radiology treatment. Endovascular therapy or thrombectomy is the treatment option used to achieve reperfusion in adults with functioning disability due to acute ischemic stroke. The goal is to achieve reperfusion of the downstream ischemic territory. Mechanical thrombectomy is the removal of the clot or thrombosis from the affected vessel by using a stent or a retrieval device. Another treatment is intraarterial thrombolysis of a clotted vessel. While the patient is having the mechanical thrombectomy, medication can be introduced into the clotted vessel, and mechanical thrombectomy or removal of this clot can be also aid in the retrieving of the clot to open up the vessel. Patients eligible for such endovascular therapy is primarily up to the judgment of the interventional radiologist. Endovascular therapy and treatment for acute stroke is determined based on the neuroimaging findings. Time of onset of symptoms is less than 6 hours from when a patient was last known well. An additional new developments in potential treatment is stem cell treatment, currently autologous transplant therapy. Stem cells found in fat tissue, blood, and bone marrow. So far, the Food and Drug Administration has not aggressively regulated stem cell clinics. Stem cell research is being widely studied as to further and potential treatments such as stroke recovery effects. Researchers hope that stem cells may someday make it possible to repair or replace damaged cells, tissues, or even entire organs. But currently, there are few treatments that have been proven safe and effective for treatment. One main reason stem cell clinics are not regulated is that the stem cells typically being used are from the patient's own body and do not, and as noted, are autologous transplant therapy, which does not require any processing of the cells prior to the patient receiving them. Another issue is cost. Patients have to pay for treatment that is not covered under insurance plans, and these costs can add up to thousands of dollars per each treatment. Safety and effectiveness of stem cell treatment requires significant guidelines and regulation. There needs to be regulated restrictions set in place for these patients not to offer hope when there is none available yet for these patients. These are just a few suggestions of new developments and potential treatment options for ischemic CVA and stroke patients. Here's a list of my references. I want to thank you for watching my video. Thank you for taking the time out of your day, and I hope you enjoyed and learned something new about the pharmacology of strokes and CVAs. Here's a list of my references that I used throughout the video. If you have any questions or would like to further discuss the pharmacology of a CVA or stroke, just let me know, and I will be gladly to share more information with you or discuss this further. Thank you.